Good morning to all of you. Thank you to Dr. Krishnamurthy and Dr. Ertem and the organizing committee of the IDPA for this very kind invitation. I am very honored to be here. It's particularly exciting for me because, in a sense, I'm back home in India and to share something that I feel very passionate about. Over the next 30 minutes or so, these are my objectives. I'd like to share with you my thoughts on what we mean by meaningful outcomes, introduce to some of you who perhaps don't need an introduction to the ICF model, describe the concepts of quality of life and health-related quality of life, and the challenges in measuring these concepts in children with chronic conditions. Introduce to you the priority framework that's guided my thinking in quantifying outcomes, and share with you two examples of development outcome measures for the population that I work with. To start, I'd like to introduce you to two people. This is Jill. She's 12 years old. She has cerebral palsy and functions at a GMSS level 5. She is unable to communicate verbally, but that doesn't mean she cannot communicate. She has ways of getting her feelings, expressing her feelings and having her thoughts known to her mother. She has a seizure disorder that's under control. She is fed by a gastrostomy tube. She is hospitalized every year for pneumonia in the winter. She's incontinent. She's a full-time wheelchair user. She's totally reliant on her mother for all her activities of daily living. She has a variety of contractures that interfere with care. She's got hip dislocations and a spinal deformity, making it very difficult to sit for any length of time. David is also 12 years old, also has cerebral palsy. He functions at a GMSS level 3. That allows him to get around independently with canes at home and a walker at school or in the community. His parents, and his father in particular, is very proud of the fact that David is not using a wheelchair. But David has become less active over the last year, and his parents want him to walk better. When we think about what we do in medicine, the science of medicine, as described by Virkov, is a model that served us very well. Disease is a pathologic entity that describes what the disorder is. In case of cerebral palsy, an upper motor neuron lesion, and understanding this will allow us to come up with ways to prevent the condition or to cure it, perhaps. And it focuses on the impairment at the level of the body structure and body function, which I'll talk about when we introduce the ICF model. The practice of medicine, however, is to use that information in order for us to fulfill this obligation to relieve or prevent health-related human suffering and to promote health and well-being. We have a good framework to apply this practice, and this is the notion of an evidence-based medicine, which has been defined by Sackett as this very explicit way of using the current best evidence to help inform the decisions we make for the individual care of our patients. In that definition, we all know that we have to integrate the best available external evidence done from very good, high-quality research. It allows us to use our own experience and expertise from our practice to integrate that with the evidence. But often forgotten is the third pillar, which is to incorporate patient preferences. And there has, over the last 2 or 3 decades, this evolution in this concept of patient-centered care that started with the evolution of the outcomes research movement. Wenberg defined this as the way to sort out what works in medicine and to learn how to make clinical decisions that reflect more truly the needs and wants of individual patients. And if that's the model we want to follow, then the effectiveness of our interventions should be judged using meaningful outcome measures that, again, reflect those goals and expectations of individual patients. So you're getting this recurrent theme, both in that definition of evidence-based medicine and this patient-centered care. So what are outcomes? Well, this is what happens after our intervention. They can be desirable, they can be undesirable, adverse events or complications. These can occur early after the intervention, they can occur in the short term, medium term, or in the long term. A successful outcome, I think we can all agree, is one that achieves the goal for which that intervention was intended. That goal could be prophylactic, to prevent something bad from happening in the future. It could be reactive, to address a particular set of problems today or ones that are going to happen tomorrow. But whose goals are we talking about? We had a wonderful session this morning at the book club thinking about perspective. Well, that equally applies here. Are we talking about the child's perspective or the parent's perspective? Is it our perspective as a clinician, or is there a societal perspective? And outcomes research is essentially the science of measuring effectiveness, defining better, and how do we define and measure that? One model that perhaps very few of you will have heard of was actually introduced by a pediatric orthopedic surgeon in the 90s. He was quite visionary in his thinking. He was in Boston at Tufts, perhaps, Don, you know of Michael Goldberg. He talked about this in the context of pediatric orthopedics as a way of breaking it down to things like technical outcomes. That's the immediate objective of your intervention. If you've got a dislocated hip, your operation's technical objective is to put that hip back into place. However, there is a higher goal, which is what he called the functional outcome. It's the reason for why you want to put that hip back into place. It might be to relieve pain. It might be to allow the child to walk better and to be able to do more. You still then have to ask the question whether the person who received that intervention was satisfied with the outcome from their perspective. And he talked about patient satisfaction. Are they happy or not with the results or the experience of the care that they received? The problem with satisfaction is that most studies that have measured satisfaction as an outcome show that patients tend to be satisfied even when other things suggest that things didn't go very well, because there's lots of things that contribute to your concept of satisfaction, and really it's a very unsatisfactory way of measuring outcomes. The fourth pillar he talked about was cost effectiveness. Is this actually affordable? And for his time, he was way ahead, at least for orthopedic surgeons, in at least getting us to think beyond what we tended to focus on, which was the technical outcome measured on a radiograph to help us pat ourselves on the back that a deformity that existed before has now been removed, at least on the X-ray. Today we have a much more systematic and comprehensive way at classifying a condition and a framework for looking at outcomes. The International Classification of Function, Disability and Health, introduced by the World Health Organization, has a child and youth subset to it. At the top, we talk about the condition that the person is living with. In this case, let's say cerebral palsy. Someone with cerebral palsy has that condition because of an impairment that occurs at the level of the body's structure. That's the anatomy, so in the brain, or the body function, which is the physiology, manifested by a movement disorder, for example, hypertonia. Those impairments may or may not be associated with a limitation in what they can do, which we call activities: walking, running, getting from A to B. And these limitation activities may or may not be associated with a restriction in participation, the ability to do the things you want to do, to be engaged in life events. The ability to participate is influenced not only by your physical or cognitive abilities that are influenced by the pathology, perhaps the impairments of the body structure and function level. However, they're also influenced by the environment and the context that you live in, and indeed by personal factors, whatever motivates you. You can have an introvert who's quite content to sit on her own and read a book and have an excellent quality of life, whereas for somebody else, it's about going out with friends. They're equally participating in different ways and have a good quality of life. And in this model, there's no mention about quality of life, but the assumption is that the more you can do the things you want to do, that contributes to your quality of life. So what is quality of life? Well, there are many definitions, and I like this one in particular. It's the individual's perception of their position in life in the context of the culture and the value system in which they live, and in relation to their individual goals, expectations, standards, and concerns. Once again, I've underlined those concepts because that's what we looked at when we talked about outcomes as well, when we talked about evidence-based medicine and the need to consider patient preferences. So it's a subjective perception of one's individual well-being. So I'd like you all to take 30 seconds to contemplate this question. Okay? So what contributes to your quality of life? Think big. And if you've got someone next to you over the next 30 seconds, share with each other what you think contributes to your quality of life. While I take a sip of water. If this was a more intimate setting and I had more time, I would get you to volunteer and shout out different things that matter to you. And every time I've done this, you generate a list, and I'm going to give you a list that I've generated from previous occasions when I've done this as an exercise. And if you don't see what you think contributes to your quality of life from this relatively exhaustive list, put your hand up and I'll add it to that list. Okay? So, some of you've talked about things to do with your family, about your social life, about your work life. Often, health comes up low down the line, especially if you're healthy. Food and drink, being independent, being financially secure, being able to participate in sports and recreation, having access to art and culture, a good education, to technology. These are the kinds of things that contribute to our quality of life. Having a roof over your head, where you live, the kind of government under which you live, having access to public and civic services, being safe and secure, having access to personal civil rights, having the right to practice or not practice religion, justice and equality, the economy, your climate, your environment, geography. And I would venture to say, as a pediatric orthopedic surgeon, my ability to contribute to anyone's quality of life is infinitesimally small, because there is far more to quality of life than even health. And that's where, at best, I can perhaps make a difference to a subset of my patients. It's broad, it's multidimensional, and it's individual and personal. So if I asked you to prioritize that list, it will be very different rank order for every one of you. You don't appreciate how important health is until you lose it, or you have someone in your family who doesn't have access to health, and that's perfectly okay. What's important to you today becomes very different, or maybe less important to you next week when your job perhaps is on the line, or there's some other crisis perhaps in your life. It's ultimately personal and therefore needs to be self-reported. And this is enshrined in the UN Convention on Rights of Persons with Disabilities, where people with disabilities and children with disabilities have a right to express their views. And we try and measure this indirectly through its domains, but it's subjective, it's dynamic, and it's contextual. And health-related quality of life is just a small subset of that. And health needs to be looked at globally. There's the physical well-being, the mental and emotional well-being, and social well-being that we have to take into consideration. Consider this. What's good for your quality of life may not always be healthy. What's good for health may not be good for your quality of life. So why is all this important in cerebral palsy, or for that matter, in any chronic condition for which we do not have a cure? Well, in the context of cerebral palsy, this is, when I say is, it really is a spectrum of disorders, but it's the most common cause of a chronic disability in children. The impact is lifelong and affects the child, the parent and the caregiver, the family at large, the healthcare system, and potentially to society in general. Let's go back to Jill. What are her problems? Well, she has these frequent episodes of vomiting and reflux that have become more problematic in the last 6 months. As I said, she's frequently hospitalized for pneumonia. She's sleeping very poorly at night. She needs to be constantly repositioned. She's able to sit for very short periods of time, and that's her way of getting around in a wheelchair. A single mother who's divorced is finding it increasingly difficult to clean, bathe, and change her, and to move her about and transport her. Jill loves to swim and to be taken for walks in a wheelchair, but where she lives, the local pool is only open in the summer, and in the winter there are very minimal snow removal services, and consequently it limits where she can go in her wheelchair. In cerebral palsy, as in any other condition, and for ourselves, quality of life is personal. As I said, it's dynamic and contextual. It can change over time and circumstances. So what contributes to Jill's quality of life when she was a young child may be very different when she's older. But whose life are we talking about? When we cannot access Jill's perspective, how do we know what Jill would want? She has significant cognitive impairments. She's nonverbal. As I said, she has ways to communicate her feelings, but I really cannot access her perspective on what matters to her. Under that context, I have no choice but to rely on the next best perspective, and that is Jill's mother, who knows her best. But the moment I do that, I have to acknowledge that that's a proxy. That's a representation which immediately must allow us to consider that at best it's a perception of Jill's quality of life. It's the next best perception, better than mine. Mixed up with that is the perceived burden or ease of caring for Jill that might influence Jill's mother's concept of her quality of life. And there may be aspects of Jill's mother's own quality of life that get entangled in her perception of Jill's quality of life. And these are very difficult to disentangle. Jill, like many other children with severe cerebral palsy, are subject to major interventions. They've got multiple medical comorbidities. We subject them to these big operations. These are resource intensive, they're expensive, they're associated with significant complication rates. Why do we do this? Well, we do this because we want to relieve or prevent pain. We do this because we want to ease or facilitate caregiving. We want to preserve or improve her health. We want to preserve or improve her quality of life. Those are the reasons why we subject Jill and others like her to these interventions. What do we measure? Things that are measurable. Things like muscle tone. Things like range of motion, things like radiographs that measure the deformity. Those are measurements of the technical objectives of our intervention. What we really need are a measure that incorporates what's important, and those are the goals that were intended by these interventions. And when you start to think about what ways can we measure these, it turned out there are very poor ways. There's some generic measures of health status and quality of life, where many of the items are simply inappropriate and don't apply to children like Jill, and many items that are missing. There are some condition-specific measures that were applied across the spectrum of severity of CP that simply are inappropriate for children with very severe disabilities. And frankly, parents who complete these questionnaires feel insulted and upset when they are asked to answer questions just don't apply to their child. Some take a societal perspective, like the Health Utilities Index, which can be used for health economic evaluations, which guide decision-making for policymakers, and they're very important, but they're very generic and take a societal perspective. In the words of the mother of one of my patients, "No one asks me what might make life better for all of us," was a turning point for me, and we realized that there really simply wasn't any outcome measure that took or considered this kind of more holistic perspective. This led me to start my research program where I wanted to understand what are the parents' experiences of caring for a child with severe CP, to really get a deeper understanding of their priorities, including their concerns, their needs, desires, and expectations, which collectively I termed as priorities, their perspective. And to gain insight that would then help us inform decisions about the interventions to improve the quality of life for the child, the family, and the caregiver. To help us do this, we established a framework of priorities for outcome evaluation. At the center is the person with a condition, in this case, cerebral palsy. Understanding what the lived experience of a child with cerebral palsy or a parent who's looking after that child allows you to understand their priorities, so what their concerns, desires, and expectations might be, and using that to understand what their goals might be. There may be different perspectives. There's the child, there's the parent, there's the family, there's the societal. There may be some convergence, but there may be lots of divergence. What may be good for the child may not be good for another sibling in that same family. What may be good for the child may not be so good for the parents, and what may be good for the family may not be so good for the society because there are costs involved as well. So it's important to understand which perspective we're taking, and it's important to reflect and acknowledge all those perspectives. They're very important. Only if we have a good understanding of these priorities can we come up with interventions to address those priorities. And by interventions, I'm not limiting ourselves to my operations, our medical or therapeutic interventions, but we need to think broader. It could be legislation, it could be policies, it could be programs and services, it could be technology, it could be architecture, it could be equipment, and our medical therapies. If indeed we have interventions to address these priorities, or we don't have interventions, we can come up with new ones. We need to understand whether they actually work. Do they actually accomplish the goals that stem from those priorities? And to answer that question, you need research, program evaluations, clinical trials, or cohort studies, but you need measures to determine whether indeed those interventions address those priorities. And if that was the intention, those outcome measures need to have an understanding of what those priorities are in the first place and embed them in those outcome measures. And so we use this framework then to start by understanding the priorities of parents of children with very severe disabilities. So this was qualitative work that involved observing, like a fly on the wall, what a typical day in the life of looking after these children were. In their homes, we gave families cameras to take pictures of the good, the bad, and the ugly over a 3-month period of time. We interviewed them. We transcribed these, and a multidisciplinary group of people met together to identify themes. We used what's called a phenomenological approach to understand the lived experience, to define these priorities and the impact of these priorities on the quality of life. We tried to capture the age spectrum, the gender, single and two-parent families, families with a single or more than one child across the socioeconomic spectrum in different contexts of the urban, rural, and suburban, in different types of dwellings. The time of the day make a difference, the time of the year, the school year or holiday time, and the effect of seasons. And I don't want to dwell too much on this, but we identified a number of factors within each of these 8 domains. Child factors, parental health, parenting and family life, supports and services was a huge one, parents' attitudes, outlooks, and feelings, coping strategies, the effect of the environment, and life events. Over the course of this study, within the participants, a child died, a parent died, a set of parents divorced, a single mother got remarried, a grandmother who was an important caregiver was hospitalized, and a co-principal investigator of mine was killed in a road traffic accident. So this is in the context of just 3 years of trying to study this. So life happens even when we're looking at this. And they were all intricately interconnected and gave us some insight then into the development of this outcome measure, the Caregiver Priorities of Child Health Index of Life with Disabilities, which was one offshoot of that initiative. This comprises of 37 items across 6 domains. These are the domains: personal care and activities of daily living, positioning, transfer and mobility, comfort, emotions and behavior, communication, social interaction, health and quality of life. And a 7th section where we asked parents to report for each of the items in the main body of the questionnaire how important that item is in its contributions to their child's quality of life. This measure is not a measure of quality of life. It's a measure of things that are important to this population. And whether that's quality of life or a proxy for quality of life is less important to me, because that becomes a semantic argument. If we can all agree that these are things, or making changes in these areas might be beneficial to the child and the parent, then what it is actually measuring is perhaps less important. In our subsequent validation work, we were pleased to see that all the items met or exceeded a threshold of importance to justify their presence to contribute to the content of this particular questionnaire. We went then subjected it to all the psychometric testing one needs to do when you're coming up with a new outcome measure. It's like any measurement, it has to be reliable and reproducible, giving the same answer when administered 2 different times, when between those 2 times the child has not particularly changed. So that's the property of reliability. It performed very well. In terms of validity, this is the property of is it measuring the thing that you want to measure? We hypothesize various things and see if it behaves in the way it would expect it to behave. And we tested against GMSDS level, as we expected. It did not distinguish between ambulatory kids with cerebral palsy, but where it was intended, which is just the non-ambulatory severe end of the spectrum, it was able to distinguish them from each other. The level 4s from the level 5s, and the level 4s from 5s from the ambulatory spectrum as well. We were very pleased to see that it discriminated amongst children who are non-ambulatory with, by fluke, an average of about 50 on a scale from 0 to 100, but distributed over the entire range of scores from about 10 to the mid-80s. And this allowed us to conclude that this was a caregiver's perspective of the child's life with severe non-ambulatory cerebral palsy, and captured issues of functional limitations, ease of caregiving, health status and well-being, with no mention whether this was actually quality of life. We then tested it against other quality of life measures, or health-related quality of life measures, to see if like concepts provided similar answers, and we were very pleased to see that. One such measure is the Health Utilities Index. It measures quality of life or health status on a scale of 0 being a quality of life equivalent to being dead, and 1 where you've got perfect health. And it takes a societal perspective by getting people, they've generated scores for different health states, and it's multidimensional, and the parents fills out this questionnaire which says, what does your child do in different health domains, and it generates a score, typically from 0 to 1. And we were very pleased to see that there was a nice correlation that as the Health Utilities Index score increased on the y-axis, the CP Chow scores increased on the x-axis. But notice something. About 2/3 of the population had a Health Utilities Index score less than 0. That's a negative, which means from a societal perspective, they have a quality of life that's worse than being dead. This is society saying that I would rather be dead than live like Jill. And I can assure you that Jill has a good quality of life. From her perspective, there are aspects of her life that are not so great, but there are many aspects of her life that contributes to a quality of life. She's loved, and she does lots of things that are fun for her. And this raises this issue about the disability paradox, this high quality of life against all odds, and that the sum of patients' problems does not equal to their perception of well-being, and function or functional deficits does not necessarily correlate with quality of life. Well, so what? Coming back to CP child, we wanted to know, is this clinically relevant? And we looked at it against the clinical morbidities that children have, and we were able to tell that the worse their GMSTS level, the more problems they had with their feeding, the presence of hip pathology, the worse their seizure status, and so on, was negatively correlated with the CP child score, which was one of our hypotheses, which suggested that indeed it was clinically relevant. That was consistent with the expanded definition of cerebral palsy that has embedded within that definition all these other comorbidities in addition to just the neurologic problem. We then had to know whether the CP child was actually responsive. Was it sensitive to change? Could we use this to measure a difference that was meaningful to kids with cerebral palsy if they were subjected to an intervention? So we tested this on children with hip instability or hip displacement who undergo hip operations. And again, I don't want to dwell too much on this. In a cohort study that was done prospectively that started off with identical CP child scores at baseline, there was a group, all of them had hip displacement, met the criteria for hip operation. Some had the operation and some, because of my shamefully long wait list or because parents declined the opportunity for the operation, deferred the operation, we were able to test how they did before and after the operation. The operations were successful technically. I knew what I was doing and we were able to get the hips back in place. When we looked at the changes in the CP child scores from baseline to 12 months later, we showed positive changes in all these red dimensions of the CP child score. That was encouraging. And in every instance, we found that at 12 months, it made a positive difference in the total score, in personal cares and ADLs compared to the baseline, in positioning, transfers, and mobility, in comfort, emotions, and behavior. They started off more painful, ended up less painful than the control group, but didn't have much of an effect on overall health or communication and social interaction, as one would expect. This was to show that it was sensitive to change, and we've done this in other interventions as well. The questionnaire has now been translated into multiple languages and back translated and culturally adapted, which now allows us the opportunity to do larger studies across different contexts to see if our interventions are making a difference. One such project is the CHOP study that's funded by the Canadian Institutes of Health Research that's currently being undertaken in 26 centers in 13 countries. That is a comparative cohort study comparing these 5 cohorts: the natural history, the use of botulinum toxin, soft tissue surgery alone, bony reconstructive surgery, and salvage surgery to treat hip displacement in children with severe cerebral palsy, which is an area of controversy. The same study design has been utilized to look at the effect of spinal fusion surgery for spinal deformities for this population, and for medical interventions and neurosurgical interventions for hypertonia, gastrointestinal interventions, seizure management, complex care, and recreational camps, and so on.
2 minutes.
In the last 2 minutes, I'd like to focus our attention on David. Not because he's any less important. He walks with canes at home. He uses a walker at school. He's become less active over the last year. He is tired. He's got knee pain. He feels excluded, especially during the summer. He spends lots of time doing therapy or exercise. He'd rather be out with his friends. His friends are at sleepover camp. And his twin brother, who doesn't have cerebral palsy, plays hockey and soccer, and he would like to do that. We do lots of operations for children like David, and this is what we're trying to do, to optimize their biomechanics and their lever arm function. But what does David want? He wants to get rid of his knee pain. He doesn't want to be tired. He wants to go out with his friends. He wants to play more. He wants to do less therapy. He doesn't want to trip and fall less, and he doesn't care about whether to use a walker or not. He wants to go out with his friends. He doesn't mind using a wheelchair if his parents would allow him to do that. He wants to look less different from others. So, these are the goals we're trying to accomplish. There are lots of measures that we apply for ambulatory cerebral palsy to see if they make a difference. Not one of them have bothered to actually ask kids like David what they want to justify the content of those measures. So we went back to the drawing board using the same framework to do just that, to find out what kids like David and their parents want, and to ensure that they are embedded in the outcome measure that can then decide whether or not our interventions achieve the goals that David wants. The new outcome measure called the GATE Outcomes Assessment List has these 7 domains. It is currently under validation. It has a very similar structure to the CP Child. Once again, the content has been deemed to be important to the population. When we look at children versus parents, we've recognized that parents consistently rate their children worse than the children rate themselves. There's a very good correlation, but the children who live with this condition sometimes feel they're doing perfectly fine. Parents tend to impose their worldview and compare them to other children. They have a very important perspective, but it might be different from that of the child. Reminiscent of the debate this morning, or the talk this morning, about looking at the cone from different perspectives. We've shown this is reliable, it's internally consistent, we've shown that this is valid, and we have a couple of studies that will be published very soon that shows that this perhaps is a better way of looking at outcomes for the intervention that we subject David to, the content of which is represented across the ICF spectrum. So, in summary, the effectiveness of our intervention should be judged using meaningful outcome measures that reflect the goals and expectations of individual patients. Therefore, they should be patient-reported. And just because an outcome measure is reported by a patient, it doesn't necessarily mean that the content that they're reporting is important to them. When it was developed, it should have been generated by patients as well. The outcome measure should be relevant and meaningful, aligned with their goals. They should be reliable, valid, and responsive. Can we measure important change? I think we can. Are we making a difference? We now have the means to find out. Thank you.